All right. Clinical disorders of the motor system. So remember we mentioned that damage to the nervous system, the most common manifestation is some involvement of your motor system is the most common. Um, so, and this can manifest themselves in several different ways. You can have a change in your muscle strength and bulk, size of your muscle. You can have a change in your ability to contract that muscle, so muscle contractions can be abnormal. The tone in your muscles, the resting tone of your muscles can be impaired. Your reflexes can change. And the efficiency with which you move, the speed of movement, or coordination of movement, we can kind of put all that in one basket, there. And postural control, being able to maintain your posture, especially upright against gravity in either sitting or standing position. So those are the ways that it can manifest themselves. For instance, go through each of those and give you a little more detail about those changes. So what do we mean by changes in muscle strength and bulk? Is paralysis, is the most profound version of this, where you're totally paralyzed. You cannot move. You have complete loss of voluntary movement and muscle contraction. And that's actually less common. I mean, it is common in spinal cord injury if it's complete, but a lot of spinal cord injuries are incomplete, so you still have some movement, even though they call it paralysis. If you have some movement, it's not really true complete paralysis. Somebody with a stroke that involves one side of their body, typically they have some movement of their arm and leg. There's the occasional person who's completely paralyzed on one side of their body, but that's kind of not as common. So this is where we get this terms paresis and plegia. So they call it hemiparesis or hemiplegia, which is a partial paralysis that involves one side of the body, and even with that one side of the body, they may be still able to move the limb a little bit in certain ways, oftentimes in more of a patterned motion. You've heard the terms paraplegia would be loss of function below a certain level, which would be legs. Paraplegia would be both your legs have some amount of weakness or loss of motor function in them. They don't have to be completely. It could be an incomplete paraparesis or paraplegia. Or tetraplegia is the term. Instead of, they're trying to get rid of the term quadriplegia or quadriparesis and replace it with tetra. It's just the same thing, but anyway, either one of those terms would be typically okay, but they're trying to say tetraplegia. So, and that doesn't mean there are tetraplegics who will walk up to you and can be walking down the hall, who have some weakness in their arms and legs due to an incomplete spinal cord injury. As long as you have some amount of weakness or involvement in all four limbs, you are technically a tetraplegic. And so there's actually, and we'll see when we get to the spinal cord region, talk about damage to the spinal cord, there's some unique presentations where, depending on where you damage the spinal cord, that you could cause loss of some function in your arms and legs and still be ambulatory with that. You'll see atrophy typically. Anytime you have loss of strength, eventually you're going to get some atrophy, so you're going to get loss of bulk. Some of that is due to the actual loss of the neurologic input to the muscle. So you lose that neurologic input, and that will cause weakness. But then another portion of that can be that disuse. If somebody who is hemiparetic or plegic, they'll have a loss of function from the nerves being damaged and the pathways to those muscles. They'll have a decrease in muscle bulk, but now they're not getting up and walking around as much. They're not moving the limb as much to maintain, so they'll have additional loss of bulk and strength in those muscles just due to disuse. They can even have loss of muscle bulk on their good side because, again, they're not getting up and doing things and moving around and moving like they normally do. Okay? Assessment of muscle strength and bulk is the next thing. MMT, dynamometry, those are how we can assess muscle strength and bulk. You've already learned how to do that, right? MMT and handheld or computerized dynamometry. Tape measure for looking at girth. Volume meters, you stick your hand or leg in a tub of water, you can look at the volume of a limb. We'll tell you a little bit about the bulk of that limb. So that was muscle strength and bulk. Another impairment or thing you can see with a motor system problem is involuntary muscle contractions. So you're having contractions that are happening that aren't necessarily under your full control. They're excessive muscle activity or movements that aren't typically normal. Okay, so things like muscle spasms and cramps. These are sudden involuntary contraction of muscles. cramps are a more severe and painful form of a muscle spasm, but the definitions on these get a little murky and stuff, and I'm not going to try to trip you up on this on the exam, spasm versus cramp. Just know that those can be associated. People with normal neurologic systems can have spasms and cramps, and there's some evidence that that is related to some neuromuscular control issue, where that's why you get the spasms and cramp. But then there's also, some potentially with certain types of spasms, cramps brought on by electrolyte imbalances and those kind of things, and that's where you drinking the pickle juice and all that fun stuff. So there's usually a combination of the two things, a neuromuscular fatigue in addition to potentially some electrolyte imbalance that can lead to these cramping and spasms. There's a thing called fasciculations. Have you heard of fasciculations? These are quick twitches of muscle fibers of a single motor unit on the surface, but no joint movement is visible. This is really basically only you feel it. Somebody looking at you, they're very common in like the face, like the eyelid. You may get one in a shoulder muscle or something where you feel this little twitch and you feel like everybody can see it, but people have to look really close. And so you're just getting this little single motor unit that's going blip, blip, and just kind of freaking out on its own a little bit. So that's, remember the motor unit is a single motor neuron is just randomly firing in your anterior horn and just making just the muscle fibers that are innervated by that single axon and that single motor, well, that axon that branches, but that single motor cell going blip, blip, and just making it contract. You may see a little visibility on the surface, but it's not moving your limb. Your arm isn't jumping around. You just feel it, and somebody might be able to see it quivering underneath your skin there a little bit. Those can be normal, but they can also be abnormal too. They can be, with ALS, amyotrophic lateral sclerosis, can have fasciculations. That's a sign sometimes that the muscle's starting to be de-innervated, and it kind of freaks out a little bit. Fibrillations are brief contractions of a single motor fiber, not a whole motor unit, but an actual little muscle fiber. Okay, remember a motor unit goes to a lot of fibers, depending on the size of the muscle and so forth, but a single motor fiber. These are not visible. You cannot see these on the surface of the person's skin. They are always abnormal. If you're having fibrillations, it means you're having some type of lower motor neuron problem. They're common with things like ALS, with neuropathies and so forth. It's a sign typically of loss of drive, central drive. You're having loss of or de-innervation of the muscle. The muscle's no longer being supplied with its normal, we call it trophic input. So our systems require some kind of trophic input typically, like your motor neurons are never like totally quiet. Occasionally you're sending signals at a certain rate to kind of keep the certain amount of resting tone in your muscles and so forth. When they start dying off, your muscle fibers, when they no longer have that trophic input, they're not sure what to do. So they start firing sometimes spontaneously on their own because they're not getting the normal trophic input of anterior horn cells driving them normally. So they might just kind of sit there and their little motor fibers, individual motor fibers might just kind of pop off spontaneously and contract. You need a EMG to look at these. You need an EMG person with a needle in your muscle to pick those up. And you'll see a little spike on a little oscilloscope or on the screen of your computer that would show that happening. Yeah. No, typically you can't feel the fibrillations. You can feel fasciculations, but not fibrillations.
So then how would they know that you even need the test?
They usually are having some other weakness associated, and the doctor might notice, hey, they've got weakness in their leg. They also have lower reflexes. There's some loss of muscle bulk. This looks like a peripheral nerve problem. We're not sure why. We need to try to figure out if they've got some kind of peripheral neuropathy, Charcot-Marie Tooth disease. Let's do an EMG to see if they've also got fibrillations. That would really show that we're truly having some de-innervation going on, without having to do like a biopsy of the nerve or something like that, which is really painful and can damage the nerve. So, yeah, good question. And then we have hyperkinetic disorders. So there's a number of hyperkinetic disorders and terms to describe those, okay? These are typically associated with some type of basal ganglia disorder. And you'll also find out tomorrow when we talk about the basal ganglia, there's the flip side of that, hypokinetic, where we're talking involuntary muscle contractions. Hypokinesis is a lack of, your muscles don't move. We're talking about problems that cause you to have excessive contractions or abnormal contractions. So there's a class called hyperkinetic disorders. So if you damage certain regions of your basal ganglia, it leads to too much movement, even potentially at rest, or even during voluntary movement. You can have excessive movement during those voluntary movements that is abnormal because you've kind of released your motor system from some controls of the basal ganglia that keeps it regulated at a normal level, and it gets hyperactive. So those are hyperkinetic, too much movement. And some of the terms we use to describe these things like tremor, athetosis, chorea, and bulismus are some characteristic hyperkinetic disorders. So I think these links will hopefully get us to videos that show you these, because it's better to see them to show you what those look like. That is that's one of the most rapid resting tremors I've ever seen. They're typically not that fast. There's somebody with Parkinson's disease bilaterally. There's a form of Parkinson's disease that's tremor predominant, and this guy's probably a tremor predominant Parkinson's. And actually, this tremor predominant type actually responds pretty well to deep brain stimulation. But you'll notice as soon as he does a voluntary movement, it goes away. It's only at rest. The tremor is only at rest, but once they start moving, it goes away. It's really kind of freaky. Huh? It almost looks like he's faking it. Like, really? Is this guy for real here? And then you'll see as soon as he stops. He literally has to rest his forearms on his lap to get it, start doing that. And it's at night when they fall asleep that goes away too. It's only when you're awake and alert and you have norepinephrine in your brain that causes this to occur. But close that one out. Let's go to athetosis. Is another type. And so athetosis is this writhing-like movement. Typically it's in the upper extremity, but not always. You can have athetosis throughout the body, and it's like this writhing, twisting kind of motion that you see there versus the shaking and rapid kind of tremor-type movements. Nope, we don't want to hear that. And this is chorea. Chorea is dance-like movements. It's associated with Huntington's disease, typically, Huntington's chorea. And you'll see, I don't know if this sound.
With abnormal involuntary movements. Choreic or choreatic movements consist of individual, brief, purposeless, non-repetitive jerks of individual muscles. They tend to be rhythmic and non-patterned. They appear in series or groups, result in rather complex movements. But movements are made more complex by the patient's attempts to mask them by purposeful movements. Here we have a patient with fairly severe choreatic movements involving various parts of her entire body. We see movements involving the jaw, the tongue, the mouth, the neck. Each is an individual brief, sudden, purposeless jerk. In this individual, the choreatic movements are due to Huntington's chorea. The individual movements, however, look the same no matter what the etiology of the choreatic disease.
There's a video of her walking, which I don't have up here, that when they walk, it looks like they're almost like dancing, and they have these choreatic movements, and then they call them semi-purposeful because they try to mask them, and then when they mask them, it almost makes them look worse. So you kind of trying to, change the movement as it's occurring, and they have trouble with that. Then this is Bulismus.
Describe another form of abnormal involuntary movements. The movements of hemibulismus involve the arm and leg on one side and are usually contorting and continuous of a rotatory nature. Hemibulismus also merges with hemichorea. The abnormal involuntary movements of hemibulismus usually come about as a result of a CVA. The lesion usually involves the subthalamic nucleus or corpus luisi, but can also involve the globus pallidus or the connections between the globus pallidus and the subthalamic nucleus. Here we have a patient with relatively continuous, severe contorting movements up his right side, involving the arm not quite as much as they do the leg. We see the continuing rotatory movements of his right leg.
I said involving the arm. He had a lot more leg involvement than arm involvement there. If it's the arm, they called it. Whoops! The heck! Oh God! I don't want to see that. That's just frightening right there. Ugh. Oh, thanks. What did I just? I just lose the. Hang on. Where am I at here? Number 5. There we go. Bulismus is, and we'll talk when we the subthalamic nucleus is part of the basal ganglia circuitry. When you damage a subthalamic nucleus, because of the role it plays in that circuitry, it releases the thalamus and causes the thalamus to be more active and cause more movement. And there's certain regions within that subthalamic nucleus that are specific to different parts of your body. It's like a small little lesion that could affect your arm, leg, or the whole side of your body. But in the arm, it causes, like, it looks like this. That kind of flip, that rotary movement, and they're flinging their arm, it looks like, and they call it hemibulismus because it almost looks like they're trying to throw a ball. It's actually, most of it looks like it's like they're almost trying to throw a frisbee, so they should call it like frisbismus or something like that. But it's very, very noticeable. And the interesting about it goes away typically on its own. Like your body is able to adapt to that and then control it. So it's usually a temporary kind of thing. Okay. And it's hard. Sometimes these there's some overlap in these and what they're like. So yeah.
Is Bulismus just on one side, or can you have it on both sides?
99% of the time it's just on one side, so it's usually referred to as hemibulismus. But there could be somebody who could have it on both sides, but that'd be really weird because you'd have to have both subthalamic nucleuses damaged at the same time. You'd have probably some other large lesion if you did that you wouldn't even be able to see the bulismus because they'd be unconscious or they'd have some problem. But yeah, 99% of the time it's hemibulismus. So you can see here, this is showing you some characteristics of these different types of movements. And there's some commonality in some areas, and then there's something that usually shows them, makes them unique or separates them. So if you look at chorea, bulismus, and athetosis, so the speed of the movement, chorea and bulismus tend to be more rapid, where athetosis is the slower movement. They're all involuntary. They are all non-stereotypical in nature. They don't do the same movement over and over again. They look a little different each movement. Chorea will look sometimes semi-purposeful because it's really non-purposeful, but sometimes it looks semi-purposeful because they're trying to cover it. So that's why it has semi-purposeful / non-purposeful. The other two are non-purposeful. The chorea can have more of a dance-like look to it when they're sitting there. This more dance-like look. The bulismus is a more violent flinging of the limb. And the athetosis, since it's more common in the upper extremity, it's more like it looks like they're almost trying to write something. So it looks kind of like they're sitting there trying to write something something big and cursive. Chorea is more distal. Bulismus is more proximal, like that's their even though the distal part of their limb is flinging, it's their shoulder girdle that's causing it to do that, or their hip that's causing their leg. And then athetosis has a much greater propensity to affect the upper limb. So, but you can see there's definitely some things that are in common. So kind of looking for that thing that separates it out will help you decide clinically when you're assessing somebody what type of movement disorder they're displaying. Muscle tone, so we're on this list of things that can change with involvement of the motor system. Muscle tone is one of those things. We can have hypotonia, which is too little muscle tone. So it's abnormally low resistant to passive stretch. We assess muscle tone through passive movement. Just lifting somebody's limb, telling them to relax, don't help me, and you move. Usually you want them laying down so they can totally relax. They don't have to support their trunk. Lay down, let me move your limb, okay? And some patients have a really hard time relaxing and letting, and some of you will have a hard time letting your partner move your limb and relax. Don't help me, come on. And then if they truly have zero tone, that's called flaccidity. None of you are have flaccidity, hopefully, but your patient who has either a lower motor neuron problem, like the whole nerve has been damaged to that entire muscle, then you could have flaccidity. If you just ripped out the musculocutaneous nerve or something, or the axillary nerve, a certain muscle or muscle group could be totally flaccid where it has no contraction. One thing you'll see is polio. Patients that have polio or polio survivors have these little tiny withered limbs sometimes that are tiny, almost like there's almost no muscle bulk. And they have true flaccid paralysis because the anterior horn cells that go to those muscles are totally gone. So they have no motor drive to those muscles, which is complete flaccidity. And it is common, so after a stroke, let's say somebody has a stroke on the left side of their brain here, and we know those cross over. It's a really big stroke, especially the arm, sometimes the leg, but mainly the arm, because the arm has much more control from those higher centers, can be totally limp or flaccid, where you just lift it and it just drops. And there is absolutely, and they just walk around, and their whole arm hangs so much that they get subluxation, because normally you have a little muscle tone to hold your shoulder in its joint. They can have flaccidity for a period of time. There's a period of time when if the central nervous system is damaged, you can go through a period of what's called neuronal shock that can last from several days to several weeks. But eventually, some tone will start to return. Once the damage, their brain goes, okay, this is my new state of, it's damaged, but I'm going to start to turn on some other pathways and things to try to make up. So they might get some tone. It may still hang. It may still be paralyzed, and they have very minimal movement, but it's not totally flaccid. And you'll start to get reflexes back. Like when they're truly flaccid, they have no reflexes as well. And you can have that. True flaccidity that lasts a lifetime is more common in a lower motor neuron, peripheral nervous system type problem. And we'll get to that in a second here. But you can have it after a central nervous system, upper motor neuron problem right after a big insult. Like immediately after a spinal cord injury, a complete spinal cord injury, their entire body is flaccid. They have no movement, and their limbs, you pick them up. But over time, they get a lot of spasticity. Like spinal cord injury patients, you tap on their reflexes and they're just going crazy. But initially after the injury, for the first several days to several weeks, they may have no reflexes at all and be totally flaccid. Flip side is hypertonia. That's abnormally high resistance to passive stretch. So you pick their limb up and you go to move their limb, and at some point it gives you more resistance than you would expect from a normal nervous system. Hypertonia, you can have spastic forms and rigid forms of hypertonia, and you can have both, okay? So you can have spastic hypertonia or spastic rigid hypertonia, where the rigid form is where you lift the limb up and it feels stiff no matter, as you're trying to bend or move the limb, and they're at rest. And even when you're doing it slowly, you feel the rigidity, okay? Or the tone that's kicking in and making it harder to move that limb. And then there's the spastic form is then the faster you move it, the more resistance you encounter. So it's a velocity dependent. It's like the faster you move it, and that's where like tapping on somebody's tending and testing their reflexes, that's a fast, quick stretch of the muscle that elicits that spasticity. That's sensitive to the faster you move it or the quick stretch. So spastic is velocity dependent. The rigid is velocity independent. It doesn't matter how fast you move the limb. It maintains the same amount of resistance no matter if you move it slow, no matter if you move it fast. Most of your patients will have Moving it slow, you'll get a certain amount of resistance. You start to move it fast, you'll initially encounter some increased resistance, as these are the most common. So most of you have some a combination of both some spasticity and rigid hypertonia. Some in the clinical world, clinicians will call the whole thing spasticity. They'll say, your patient has spasticity, and they're meaning both. They have velocity-dependent spasticity plus hypertonia, even this rigid type of hypertonia. So, but they are different. But most people throw this all under the term spasticity, and so you just got to be careful with that. Is that spasticity really is velocity-dependent tone, where the rigidity is more independent. There's a different type of rigidity with Parkinson's disease that is not, it is a form of hypertonia and it's rigid, but it's a different mechanism behind it versus like a stroke that involves the cortex or the upper motor neuron pathways versus the basal ganglia, okay? Damage almost anywhere along the motor system can alter muscle tone. For an upper motor neuron lesion, and we're going to get to what this means, but an upper motor neuron lesion is damaging anywhere from the cortex through any of the white matter tracts that are descending through your brainstem and spinal cord before they get to your anterior horn cell. Damage anywhere in there is an upper motor neuron problem. Where if you damage the anterior horn cell or the peripheral nerve, that's a lower motor neuron problem. But so with upper motor neuron lesion, you can have that initial CNS shock that can cause that flaccidity and low tone, but then eventually you start getting higher tone several weeks to several days, several days to several weeks later. There's some interesting forms of tone that are kind of these classic presentations. You might see one is decerebrate rigidity and another is decorticate rigidity. And if they have it bilaterally, and I'll show you pictures here in a second. So decorticate rigidity is where their upper body is flexed like this and their lower body is extended. And if they have it at the same to both arms and both legs, that means they have a severe brain injury that involves the cortex, both sides of their brain, okay? Decerebrate rigidity is where they're presenting with their head and their trunk extends, their arms are extended, and their legs are extended. And so everything's extended. And that is an even more severe form. That means even their brain stem is involved at that point. Okay, and that's called decerebrate rigidity. Those patients, if somebody's got true decorticate or decerebrate rigidity, they usually have a brain injury that's bad enough that you're not doing a lot of active physical therapy with them. You're working on positioning and those kind of things so they don't get like bed sores or lose range of motion. Especially people with decerebrate rigidity, sometimes I've had patients, they've extend so much that the only thing touching is their occiput, their scapula, and their heels. And they're extended off the bed into arched like this. And so they're going to get really rapid breakdown in their occiput, shoulder blades, and heels. And that's a very severe form, and that means you're touch and go. There's probably not a good chance of you recovering from this injury if you've got that severe of decerebrate rigidity. So you're putting on these multi-POTUS boots. You're maybe trying to do side-lying positioning. Sometimes positioning the person on their side reduces the tone because the sense of feeling that their body gets from the bed, they push into it. Without them, they're not conscious of that, but they push into that resistance. So getting them on their side, there's less to push into. So, but it's sometimes even hard. I've had people so rigid that you cannot physically break their knee. Like you cannot flex their knee at all. Like literally, you're just fighting a losing battle with that. Sometimes though, you get them on their side and you start rotating their trunk a little bit, then sometimes you can get their knees to loosen up enough to bend them a little bit and do a little bit of range of motion while they're in a side-lying position. Just massive head injury. I was telling you guys about the bullfighter, the cowboy who was doing the bull riding, and he had or severe car accident or motorcycle accidents and things like that where they've got severe brain trauma. And usually what happens is it's usually a matter, they can start with decorticate rigidity, so they damage their brain during the initial insult. Boom, the head gets rattled around in there and they get damage to the cortex and they're decorticate. Then they progress to decerebrate, which is even worse, because then the swelling, they start getting swelling in their brain, and that pushes their brainstem into the foramen magnum, and then the brainstem starts getting pushed on, and then they go into decerebrate rigidity. Okay. Now, people with stroke, when they have stroke on the left side of their brain here, and their arm tends to be more flexed on the right, and their leg is more extended, that is a form of decorticate rigidity. So stroke patients present with a hemi form of decorticate rigidity. It's kind of the same reason why they tend to hold their, and we'll show you some pictures here and kind of explain why that occurs. Okay. I remember decerebrate is extension for both limbs because it's got more E's in it. E. Extension, extension, extension. So that's how I remember it. Then I just know that decorticate has to be flexion of the upper body and extension of the lower body. So here's the different presentations. The first one is the decerebrate, and then the decorticate posturing there. So why does this occur? And we'll kind of draw it out a little bit to you. So we have certain tracts in our, yeah. Yeah. Yep. If they get into it and immediately reduce the swelling, or they just happen to recover. But if you're in decerebrate, the chances are lower. Certainly, they're pretty guarded. Your prospects at that point, unless they can rapidly reduce that and see that change pretty quickly. So why do we get this bias to the positions with damage to the cortex or the brainstem? If you remember, we have certain tracts that tend to bias extension, okay, that arise in our brainstem. Some of these brainstem pathways, and these are some of our medial activating pathways. If you remember, these medial that go to our posture and gross movements of our trunk and limbs. These also tend to function pretty normally with minimal cortical influence. So the pontine reticulospinal tract and the lateral vestibulospinal tract in particular tend to innervate muscles that keep us upright and extend our body against gravity. And they don't need a lot of cortical input from higher centers to keep them functioning normally. They kind of do their own thing relatively well without needing a lot. However, we do have tracts that tend to bias flexion to counteract those extension bias tracts. So we're always walking this fine line of balance between flexion and extension, depending on the task we're doing. And so some of those tracts are the medullary lateral reticulospinal tract, which is a part of the lateral activating system because it tends to bias flexion. And it inhibits the extensors. It helps to counteract some of these guys when it's working normally, but it needs the cortex. It needs cortical influence to do its job of balancing out these extensor bias tracts. We also have the rubrospinal tract. That's also a brainstem tract that biases facilitation of upper extremity flexors. Too much upper extremity flexion we get then without cortical influence. So this one also, the rubrospinal tract needs some cortical influence. So if we have a lesion up here in the brain, and it's affecting these descending pathways that go down, cross over in the low medulla to go to the other side of the body here. We're going to draw in a rubrospinal tract here too. It crosses over right away, right? It goes down to go up and bias some upper extremity flexion here. If you damage, and there's some little collaterals that come off your cortical spinal tract that help keep the rubrospinal tract functioning normally. It requires some influence to function normally. So if you have this damage up here, you lose some of that control over the rubrospinal tract. And now all of a sudden the rubrospinal tract actually does too much flexion of the upper extremity. This is for decorticate. We're talking decorticate rigidity right now. So this is going to be decorticate. So if you lose the cerebral influence, because you've got decorticate as the cortex, more towards the outside of the cerebrum, higher up, not the brain, no brainstem involvement here. So this is just the cortical region involved here, common with like a stroke. or brain injury. You lose that influence over the, it's actually a little bit of an inhibitory influence of the rubrospinal tract. So the upper body goes into too much flexion because the rubrospinal tract goes a little haywire and creates too much flexion. But you also lose the ability of this medullary lateral reticulospinal tract from inhibiting these guys, and they already do a pretty good job without cerebral influence, and now this guy can't balance them out, so now you get too much extension especially for the trunk and the lower body. Okay, upper back, trunk, and lower body. So now all of a sudden you've got too much extension in your lower body and too much flexion in your upper body because of the combination of actions going on here when you have damage up in the higher center of the cortex. Okay. That's decorticate. Now decerebrate, what happens is, remember you've got your rubrospinal tracts, red nucleus right here. If you damage the brainstem, anywhere in the brainstem, these are way up high in the midbrain. These pathways go down and go to the upper body to help create flexion. If you have any damage throughout the brainstem, you're going to impact those rubrospinal pathways that help to bias upper extremity flexion. And if you lose that influence, now they get too extended. They're unbalanced, and now your arms go into extension as well. And then you have your pontine and medullary reticulospinal tracts down lower here that are still going to bias you into extension in the lower body. You've also cut off any influence from the cortex coming down by this lesion, and so you've lost cortical influence, plus you've also lost the rubrospinal tract influence. So that's why everything all the rest of the tracts below that, all the rest of the medial activating system tracts that are below the level of the rubrospinal tract are all extension bias tracts for the most part. So you just the whole body then goes into extension when you have the brainstem involved versus the cortex. Does that make sort of sense right now? It might take a second or two or a month or two to sink in, or a lifetime. But it is kind of important to understand why you see the presentation, especially you're often not going to be seeing these patients, but your stroke patients are displaying a form of decorticate rigidity, the way they hold their limb and upper extremity inflection, because of this combination of factors that occurs when you lose some inhibition of the rubrospinal tract and also lose some balance of the other medial activating brainstem tracts that tend to then bias your lower body and trunk into extension. And so they have a hard time bending their leg, and they have a hard time extending their arm when you've got a stroke because of this bias of these lower centers that they tend to, the influence they have over your motor system. Okay? All right. Any questions on that? Assessing muscle tone is another way we assess the motor system. So passive range of motion. Just lift their leg up and passively move it. We can do there's a couple clinical ways of rating muscle tone and spasticity. One of them is called the modified Ashworth scale. That's the one we use the most here in the United States, and you'll hear referred to the most. There's also the Tardo scale, which is becoming a little more popular again. You'll see it in research. Some people in Europe and in certain clinical centers, even here in the US, will use the Tardo scale. And I'll show you what those are. So here is the modified Ashworth spasticity scale. A 0 is actually normal, means no increase in muscle tone. Okay? So this is defining spasticity with a 0 being normal. It doesn't mean they're flaccid. If they were flaccid, you would say patient is flaccid or hypotonic. A 0 means no increase in muscle tone. A 0 is normal for the modified Ashworth scale, which is a little bit kind of counterintuitive. A 1 is a slight increase in muscle tone manifested by a catch and release or by minimal resistance at the end of range of motion when the affected part is moved into flexion or extension. So if I lift your leg up, a 1 would be, I go to lift your leg up and bend your knee and I feel a little initial catch where it's a little hard to unlock the knee. But then once I unlock the knee, it moves really pretty easy. That's a 1. Or I lift your leg up, it bends pretty easy, but as I get to the end of the range, I notice a little increased resistance. That's not capsular or ligamentous or contracture related, muscular tightness. It's a neuro kind of sense of the muscle fighting back at me at the end of range. And it takes some skill and time of feeling enough people's limbs and legs and arms to know what that feels like versus a muscle or joint tightness versus like some resistance from the muscle as you get to that end of range. A 1 plus is a slight increase in muscle tone manifested by a catch. You get a catch when you go to unlock the knee or bend the elbow, followed by minimal resistance. So you do feel some resistance, a little more than you would expect than if somebody didn't have any tone or any abnormal tone, through the remainder, but less than half of the range of motion. So through the remainder, but less than half of the range of motion. So you get a little catch when you do it, and you'll feel maybe some resistance through the first half of the motion, but not 50% of the motion, or maybe at the second half, but not the first half. So you kind of, again, you're kind of making a judgment call. Is that less than half the range of motion I felt that resistance, or more than half the range of motion? Number 2 would be more marked increase. That's really defined well, isn't it? A more marked increase in muscle tone, but it's through most of the range of motion. So that's what really, you're able to move the limb easily still though. You you bend it, there's a catch, and it feels a little stiff as you move it, but you're not having to grunt and groan to try to move this limb. It's just, yeah, I feel some increased resistance when I'm doing that, but you're not having to work too hard. That's a 2. A 3 is considerable increase in muscle tone. This is where you're struggling. You're having a hard time moving that limb. It's like you got to work at it. You might have to twist their leg around a little bit of their arm and try to get it to release, but you're able to get it, but it's work to move that limb. That's a 3, okay? A 4 is they're rigid. A 4 is that decerebrate or decorticate posturing where you just can't even unlock that knee or bend that elbow because they're so rigid. Their tone is so strong. Okay. That is the modified Ashworth scale. The modified, they added this 1 plus category. It used to be just a 0 to 4 without the 1 plus in there. The Tardot scale is a 0 to 5 scale here, and it's got 3 different velocities that you move the limb through to do this, and you're grading. The V1 is used just to measure the passive range of motion. This is as slow as possible you're moving their limb and you're looking at passive range of motion. Only V2 and V3 are used to rate spasticity, okay? Because then you're actually moving them a little faster. The V2 speed is the speed of the limb as if if you just drop their limb and gravity pulled their limb down. I don't know exactly what that is. You have to kind of imagine how fast that's the speed you're trying to move their limb is the equivalent of that. A V3 is as fast as you can move their limb without hurting them, and trying to move it faster than gravity would drop the limb. Now that gets really tough when they have really a lot of spasticity, because if they're so spastic, how do you freaking move that limb faster than but that tells you a little bit about their tone. And then you rate their quality of the muscle reaction according to this 0 to 5 scale. No resistance through passive movement, slight resistance with no clear catch or at a precise angle. 2 is a clear catch at a precise angle followed by a release of the muscle. 3 is fatigable clonus, means that when you go to move their limb fast, it starts bouncing back at you, clonus. But it lasts for less than 10 seconds and it occurs at a precise angle. 4 is unfatigable clonus. That means if you keep the stretch on that, or you try to move that and you hold that leg or that foot will just keep beating back at you, or that wrist, as long as you hold the stretch. It'll just keep doing it and won't fatigue out. That's unfatigable clonus. And then 5 is you can't even move the limb to test it. Okay, so. And if you get a chance, I'm hoping that something between you guys' schedule change every week, but if you can see Randy, or Randy is a person with stroke who's been coming. He's got a lot of spasticity and clonus in his leg, and he would be happy to let us just during one of his rest breaks take his brace off, let you guys move his leg, elicit his clonus. He sometimes, when he gets fatigued, he gets clonus while he's even walking the treadmill. His leg will start to shake, and he has to put some weight through his heels to keep that quick stretch from happening. But he's probably a 3, sometimes a 4, depending on his fatigue and the activity he's doing. We could probably keep his clonus going for a pretty long time. We've debated with him over and over about whether we could benefit from some Botox injections to reduce that clonus and spasticity. However, Botox doesn't work like magic, and sometimes it has negative effects. But also, he's getting ready to start a study, and I asked the study coordinator, is Botox a exclusion criteria, because they don't want people having some change in their tone during the process of the study that could affect the study outcome. So they said yes. So we're definitely not doing Botox right now, because that would eliminate him from being a participant in this treadmill training study. So reflexes, let's get through this and then we'll take a break. Different types of reflexes can be used to assess the motor system. There's cutaneous reflexes. These are things where you're just touching or scraping the surface of the skin, and it can elicit responses that it can be normal or abnormal. We've mentioned the Babinski response, right? Where you scrape the bottom of the foot and you come up along the lateral border of the foot up underneath the metatarsal heads pretty firmly. And I'm hoping, we should probably have time on Thursday to go into the lab and do a few of these things. Did you guys do any of those in medical diagnostics at this point? Did you kind of talk about, or not really? But do a Babinski reflex, do some of these other things that we'll talk about, coordination testing and that kind of stuff. So you'll feel good about that before you go on your general medicine rotation, which you'll probably be asked to do some of those. Babinski reflex is a flexor withdrawal response where you tickle the bottom of the foot, or to see if they withdraw from that, how strong that withdrawal response is. The abdominal reflex, where you scrape up the side of the abdominal region, look for the umbilicus to move towards that side. There's also a thing called the glabellar reflex, where you tap on the head like this. And usually what happens normally what happens with the glabellar reflex is you blink the first time or two when somebody taps on your head, but then you realize this is not a non-threatening stimulus and you stop blinking. Somebody with Parkinson's disease, it's interesting, this is a test for Parkinson's or basal ganglia disorder. You tap on their head and they blink every time, no matter what. They never stop blinking. But a normal response would be to blink the first time or two and then stop blinking with somebody tapping on your head. So you guys can try that sometime if you want with your friends. We already know deep tendon reflexes, right? Those are testing those nerves going to those muscles that are easily able to provide a quick stretch to with a hammer, and it's telling you about a little bit of the integrity of the nervous system that's going to that nerve. And typically if they have a hyporeflex, if they don't have a strong reflex, that would typically indicate a lower motor neuron peripheral nerve problem. If the reflex is higher than expected, that would be an upper motor neuron problem, typically something in the brainstem, spinal cord, cerebrum. Then we have a grading scale for deep tendon reflexes. It's a 0 to 5 scale, but they all have a plus attached to the end of them. There's not just a 1 or a 2. They're all just a 1 plus 2, and that gives them a little bit of a distinction from some of the other grading scales, I think is why they probably did that. But so a 0 is absent. You have no muscle contraction, even with reinforcement. Did I talk about the Chandrastic maneuver, where you have them do a little bit of an isometric contraction of the upper lower body? Even with that, they don't get any muscle response. That's a 0, and that would be abnormal. So you should have reflexes, and if you do the reinforcement, you should be able to elicit some little slight response of the muscle if you're doing your reflexes right. 1 plus would be hyporeflexia. There'd be a slight or sluggish muscle contraction with little or no movement. Reinforcement may be required to elicit a more stronger response. A 1 plus could be, if it's symmetrical and the person has no other reason to believe they have a neurologic problem, that could be normal for them, just their normal state of their nervous system, a 1 plus. When certain muscle groups are just harder to get into and elicit those responses. So hyporeflexia, but if it's different, if they're hyporeflexic on the left and not on the right, then that's indicating there's a change or something different going on there. So you're looking for symmetry there. Normal is typically a 2 plus, slight muscle contraction with slight amount of joint movement. You might see the joint move a little bit. Hyperreflexia is clearly visible, brisk muscle contraction with moderate joint movement. Again, this could be normal for that person if it's symmetric, and they just tend to have that kind of higher tonal set. They're a little jumpy, a little anxious type person. Room is cold, they're nervous, that kind of stuff. 4 plus is always abnormal. There's strong muscle contraction with 1 to 3 beats of clonus. So you tap on their knee, and their knee goes flying, and then it goes boom, 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 boom by itself on its way down. It keeps eliciting its own quick stretch. And if you tapped on the tendon the first time, it goes up, and then as the leg's falling, it's creating another quick stretch, and then it finally goes down. That would be a 4 plus. And the reflex may even spread to the contralateral side. You might even see the other side their knee kicking out when that's happening. 5 plus is very abnormal. That's strong muscle contraction with sustained clonus that just keeps bouncing that leg. Let's take a break right there. So the next thing we can see with a motor system problem is problems with movement, efficiency, and speed, also known as coordination. Okay? The way we test for that is through observation. By just watching the person move during normal life, watching them walk, watching them get in and out of bed, sit to stand, but also through things like finger to nose testing, rapid alternating movement testing. We can do that for the upper and lower limbs, like tapping the toes or turning your hands, palms up and down quickly, and just seeing how quickly they can do that or slowly, and how coordinated that looks. We also do a heel to shin test, where we kind of have them drag their heel up their shin, see if they can maintain it on there, or if they slide their foot on and off their shin, those kind of things. So. Postural control is the last thing that we'll mention as far as movement system problems, typically through some type of observation. There's a test we call the Romberg test, and basically you just have the person stand there, feet just kind of shoulder width apart, maybe slightly narrower, stand with your eyes open. Now stand with your eyes closed and see if their postural control changes. And that tells us a little bit about the ability to use their proprioceptive system and their vestibular system for controlling their trunk when their eyes are closed. And you take vision out of it, okay? The Tonetti, Berg Balance Scale, those are all clinical balance tests that some of those give us some indication of postural control. Kind of the gold standard is more with these Biodex Balance Master System or the Neurocom system. You know the Biodex unit in there, there's like a little platform you stand on. You can see your center of gravity, and you just stand there, and it'll measure for 30 seconds. You do it 3 times. It'll measure how much sway you have in your postural system, your center of gravity, center of mass, how much is swaying. And there's some normative values it'll compare you to for your age and see if you're in those normal ranges. Having somebody walk heel-toe, or up on their toes or on heels will give you some idea. That's challenging to the postural system to see how that affects that. I think this concept is really important to understand, is that essentially you can put almost any neurologic disorder into one of these 4 categories. You can fit them into one of these 4 categories. There are patients that fit into multiple categories, and we'll talk about that. But there's lower motor neuron problems. This is just for motor problems, right? I'm not talking sensory here. This is just motor problems. So there's lower motor neuron problems. That is where you have damage to the lower motor neuron, the axon or the cell body from the anterior horn cell out into the nerve till it goes to the muscle. Upper motor neuron disorders, okay, which are the white matter pathways from the cortex, brainstem that are traveling through the spinal cord before they get to the anterior horn cell, the descending pathways. Any damage to the descending pathways is called an upper motor neuron problem or upper motor neuron disorder. Some books, and you'll hear the term referred to, these are often referred to as pyramidal tract disorders, because the pyramidal tract is the cortical, there's cells up in your brain called the Bett cells, which are the origination of your cortical spinal tract fibers that are large and pyramidal in shape. They're the pyramidal tract, but that's a little bit of an outdated, outmoded term, but it's an upper motor neuron is the same thing. If you hear that term, it's a pyramidal tract disorder. That just means an upper motor neuron disorder. Then we have basal ganglia disorders, okay, which is some damage to the basal ganglia nuclei, which we'll talk all about tomorrow. Those are generally considered an extrapyramidal disorder, even though it's up in the cerebrum. it's damaging the nuclei and the basal ganglia nuclei that influence the descending pathways, but the descending pathways aren't actually damaged. It's the basal ganglia that's damaged, not any of the upper motor neurons. But they do have some influence over those, and that's generally considered an extrapyramidal disorder because it's outside of the it's not affecting the actual corticospinal tracts and white matter tracts. It's affecting the basal ganglia nuclei that do have some influence over them, but not directly damaging those. The other one is called cerebellar disorders. The last one is some damage to the cerebellum, which again influences your descending pathways, but you can have a cerebellar problem without damage to the actual upper motor neurons. So it's considered an extrapyramidal disorder. So basal ganglia and cerebellar disorders are extrapyramidal, even though they influence movement and they influence those descending pathways. Those descending pathways are fine. It's just that you've lost some normal moderating control mechanisms over those that the cerebellum and the basal ganglia provide. So let's go through each of these and give the characteristics on how it affects each of those manifestations we just got done going over. So the clinical manifestations of a lower motor neuron problem will be, typically you will have some decrease in strength and bulk. And if you've wiped out an entire nerve, peripheral nerve or the anterior horn cells like in polio, you can have flaccid paralysis that never gets better. It just stays flaccid because you've damaged the lower motor neuron, the final common pathway nerve that tells that muscle what to do. There's no way for a signal to get to that muscle anymore. Does that make sense? If you've damaged that lower motor neuron. As far as abnormal muscle contractions that occur, you will see fibrillations. If you have a lower motor neuron problem, eventually your muscle will go a little haywire and you'll get those little random firings of individual muscle fibers that only an EMG person can find or pick up. Okay? Those fibrillations will come along with these lower motor neuron disorders. Muscle tone is always going to be decreased. If you try to move that limb, it's going to be lower. It's going to be hypotonic with a lower motor neuron problem. Reflexes will be diminished. I shouldn't say they're not always absent. They'll be diminished or absent. You'll have a 1+ or a 0 on your reflexes if you've got a lower. If it's affecting the muscle that you can actually test a reflex in, okay? Like if you've got a lower motor neuron problem that's going to your glute muscle, it's hard to you can't test there's no reflex for the glutes. But you just have to kind of assume that if you could, they would be diminished. There's movement efficiency and speed will also be impaired because if you can't contract the muscle, you obviously can't move quickly or efficiently because you can't generate the muscle force to do that. Postural control, it could be impaired, especially if the person has damage or lower motor neuron problems, especially in the lower limb, at the ankle and knees. Like this is very common peripheral neuropathy. Peripheral neuropathy, like diabetic peripheral neuropathy or idiopathic, that's a form of lower motor neuron problem. And if your ankle muscles and gastroc are weak, you might sway a little extra. Your postural control might be a little lower because your muscles are not strong enough to really react and hold yourself in a good position. But on top of that, usually the sensory nerves are also impacted because they're all being carried in the same peripheral nerves. So you get motor, and they can't feel the bottom of their feet, so they're not getting good, adequate proprioceptive feedback. So that also, you got both the weakness in the ankle plus the loss of sensation in the ankle and bottom of the foot that make it hard to maintain postural control. Okay? Obviously, if you have a lower motor neuron disorder, like you have a carpal tunnel syndrome, and the median nerve is weak, that's a lower motor neuron problem, and you may have some sensory deficits in your median nerve distribution, but it's not going to affect your postural control because it's not affecting muscles that are involved in postural control. Okay, so it could impact postural control only if it's involving muscles that are helping with postural control. Examples of lower motor neuron disorders. These are some of the common ones. Guillain-Barré syndrome. So Guillain-Barré syndrome is a autoimmune response where your own body damages the ventral roots of your spinal cord, which are where the motor nerves come out of. So Guillain-Barré causes lower motor neuron deficits because it's actually damaging the ventral roots. So it's the anterior horn cells are right there. Then the axons start coming out the ventral roots. You damage the axons coming out of those ventral roots. That's a motor problem. So Guillain-Barré is very motor in nature. It has some little sensory depth sometimes changes, but it's mostly pure motor, lower motor neuron problem. Polio, it causes damage to the anterior horn cell itself. Even though it's in the spinal cord, that is where the lower motor neuron starts. The pathway is coming down, the upper motor neuron comes down to tell the anterior horn cell what to do, but the anterior horn cell, if you damage the anterior horn cell on out, anywhere along, that's still a lower motor neuron problem. Radiculopathy, if you're impinging or pinching a nerve in your neck or your back, after it's come out of as it's coming out of the foramen, after it's come off the spinal cord, that's a lower motor, you're damaging peripheral nerves. And then peripheral neuropathy, which we mentioned, is also very common. Diabetic or idiopathic neuropathy is wasting away damage to peripheral nerves, the lower motor neurons. It's common to see a neuropathic gait in peripheral neuropathy. Let's see what this. If you see this guy walking here, oh, that was quick. Let's replay. Watch his ankles and knees. What do you see there with that? So there's a guy in my neighborhood. I've been watching him. He walks every day in my neighborhood, and I've watched his idiopathic neuropathy get worse and worse over the 13 years or whatever I lived in that neighborhood. And I've never said anything to him. And I'm about ready to say, hey, buddy, there's some really good carbon fiber AFOs out there now that really probably can make your walking look a lot more normal, but he's a really jerk, so I'm like, I haven't been as, no, I'm honest, this guy's a real jerk. He's like the neighborhood guy that everybody hates, so, but now I'm moving out of there, so, well, he'll figure it out. So, if you'll notice when that guy was walking, the couple characteristics, what did you see at his ankle? They were dropped like this. He couldn't dorsiflex. He wasn't dorsiflexing his ankles. I'll show it again here in a second. So his foot would drop, and so if he didn't do something to compensate, he would drag his foot. So what does he do to compensate? He bends his knee more than normal. So he's doing this, bending his knees because his feet aren't going to clear because he's not lifting his toes up. That's called a steppage gait because it's like they're overstepping. It's called this is a neuropathic gait or a steppage gait, and oftentimes you'll hear their foot kind of hit loudly, so it'll be, and a lot of times they'll land with their the foot flat, or their forefoot, not their heel, because they can't lift their toes up, heel toe, because they have weakness in their gastroc. Dorsiflexors can't dorsiflex, so they have to make up with doing more of a steppage type gait. Replay that.
So is his left leg a little stronger because he was kind of hitting with his heel there?
Yes. Let's hang on. I think let's try it. Let's watch it again. That's pretty flat-footed. He's kind of what he's doing. He's compensated because he throws it out to land on his heel. So he lifts his leg up. He uses his quad to throw it out so that his foot gets far enough out to kind of land with his heel so he doesn't land with his forefoot. So if they don't always land with their foot, if it's really severe and they're taking very short steps, they might land with their forefoot, but he's kind of throwing his leg out so it looks like he's getting almost a little bit of a heel, but kind of contact. So that's lower motor neuron syndrome. The next is upper motor neuron syndrome. The clinical manifestations is you will get, with muscle strength and bulk, there is some weakness with upper motor neuron syndrome. You've damaged those descending pathways, so the anterior horn cells aren't getting the normal drive they get, so there is some paresis, potentially, palegia, but it's not usually flaccid paresis. It's and it's because of loss of some muscle strength, you'll also have some loss of muscle bulk, but it's not as much as if you've damaged that lower motor neuron. So they're still getting some drive. The anterior horn cell and the peripheral nerve are still intact, and that provides some trophic drive to the muscle. Plus, they might have hyperactive reflexes that make the muscle contract enough that you maintain some muscle bulk, but it's still, you do typically get, like a stroke patient, even if they're really spastic, will tend to get some atrophy over time in their arm and their leg. Okay, but it's not as profound as somebody with polio or somebody with peripheral neuropathy. Muscle contractions, you will see oftentimes some fibrillations. They're not quite as many or severe as somebody with lower motor neuron problems. They will sometimes have spasm and cramping because of their increased tone and spasticity that they perceive as a spasm or cramp. Their muscle tone will tend to be increased. And they'll also have velocity-dependent spasticity many times with upper motor neurons. So resistance when they're just moving your limb slowly might be increased, but also when you quick stretch their ankle or knee, you'll get some clonus or hyperactive reflexes that are velocity-dependent. They may have that clonus. When we get to spinal cord injury, that's a little somewhat unique. Spinal cord injury, because of damaging all descending input from the white matter tracts, upper motor neurons, you will get, at rest, they will look like they have low tone. If you move their leg really slowly, they look very low tone, but they still, if you move it quickly, they have lots of spasticity. It's because that's especially with a complete spinal cord injury where you've damaged all descending input. Stroke is never usually an all or nothing event. So stroke, you still have some descending input to the nerves where they have resistance to, they have increased tone even at rest. Versus spinal cord, if you've really got a complete spinal cord injury, you lose all descending input. The reflex arc is still intact, but you don't have anything, you don't have those descending pathways from the brainstem still intact from the medial activating system that you do with a stroke up in the cerebrum. And so they tend to actually have pretty low tone when you just rest and if you move the limb slowly, but they still have really active spasticity when you stretch their ankles quickly and lots of clonus and those kind of things. Reflexes for upper motor system are always typically increased. Then they have often abnormal cutaneous and primitive reflexes, so like a Babinski reflex. There's also some other reflexes we'll talk about, like a pronator drift, where you sit there and their limb will pronate automatically. This is a type of reflex that we test for subtle hemiparesis, and so you have the person close their eyes. If you think they have had a small stroke and they go, they've got a stroke on their MRI and their cortex on their left side, and they're saying, my hand just doesn't feel right, it feels a little numb and a little weak, you might say, okay, put your hands out like this for me, palms up, close your eyes for 30 seconds, and you just watch it. And if they have subtle weakness, the arm might drop a little bit, but their hand will drift into pronation without them even noticing it. That's called a pronator drift, and that would be a sign of an upper motor neuron lesion, a subtle upper motor neuron lesion in the cortex, typically, for that's affecting their right side. Movement efficiency and speed, they're going to have trouble. They're going to be impaired. They might have abnormal timing of muscle activation, and especially loss of fractionated movement, especially if you damage those cortical spinal tracts, the one that start up in the cerebrum, that's for fractionated movement. Remember, the medial activating pathways in the brainstem are more for gross movement and posture, so you'll see them lift your arm up because they're using their scapula and their shoulder girdle to kind of do this, but they can't move the muscles that isolate movement or fractionate movement because you've damaged the cortex, which is mainly for the fractionation. Or the leg, lift your leg up, and they'll do some gross movement of the leg to try to bend it. They can't bend it straight up like this. It's kind of like the synergistic flexion pattern when they do external rotation of the hip and they do this, and it may be really hard for them to do it because they get their extensor tone biased already. So postural control, that can be impaired depending on the lesion. If you've got a really spastic leg and weak leg, trying to walk on that or stand on that, you're going to have impaired postural control and reactions. Or Randy, when he gets on the treadmill and his clonus kicks in, that's going to impair his postural control on the treadmill while he's standing and walking if he's got this clonus kicking in. So abnormal cutaneous reflexes. Here's the Babinski sign showing you, I think it shows you normal and abnormal responses. Gonna watch an advertisement first. That reminds me, I gotta get something for my wife for this Friday.
Hi, my name is Paul, and I'm here with this young lady who is 50 years old, and she's had about a 10-year history of questionable MS. Seems to be a mild case, but I just wanted to show
Sure.
you and demonstrate a Babinski sign. So what you would do here is have her rest the hand
This is called hot. This is another sign of upper motor neuron deficits.
right here, the DIP joint, and then you just flick the end of the finger and observe the thumb and forefinger as they come a little bit closer together. There.
If they do that, if your finger does this, when you flick that DIP, that's another upper motor neuron sign. It's kind of a form of a cutaneous reflex, so you're flicking the joint here. So like if somebody has really subtle deficits, you could do the pronator drift to check for it, plus the Hoffman sign to see if they get that. And then that would be there's definitely something upper motor neuron going on here.
And we're going to do Babinski with her also. And see how the big toe and toes want to splay out. So if you observe this in a patient who has maybe some slight alteration in gait, you may want to make sure that you check these to rule out MS or a central nervous system type issue. Thank you.
So I need to, next time I go visit my brother, I didn't want to do it while I was at his wedding, is test him for some of these, because I don't know if my brother has MS, and he does very well, and you would never know looking at him. I've seen some slight changes in his gait over time, but you'd have to be a therapist to probably pick those up. Anybody else would not notice them, but I have not tested him for upper motor neuron deficits. He has lesions in his spinal cord and brainstem and cerebrum. Fortunately, those lesions have not seemed to have affected a major pathway or tract, but I'd be curious to see if he does have any upper motor neuron signs now. Yeah.
So if the fingers come together for the Hoffman's test, is that a positive?
That's a positive response. Yeah, normally they would just sit there and not do anything. So any kind of movement of those fingers would be a positive response for that. Yeah, so.
And then what's the normal spot for Babinski when they don't have the
Babinski would be actually the big toe would actually do nothing or go down a little bit. And the smaller toe, normal Babinski would be your foot goes down a little bit like this. Yeah. And the other four toes come together as they come down a little bit versus going out and the big toe going up. So. It's funny. So when I'm recording these right now, and so I'm recording the YouTube through Snagit, and I don't think they'll pull me down for those, but so I've shown some videos like Red Bull stuff of crazy, people doing crazy stuff for balance and examples, and then I get flagged and they pull my video down because I've redistributing, because I post this stuff on YouTube. So hopefully we won't get this pulled down. Because some of these videos, if they're not selling a product or it's not sponsored or something like that. So muscle spasms you might see with an abnormal cutaneous reflex, a flexor withdrawal reflex to inoculous stimuli. So you barely touch the bottom of their foot. Maybe you're doing a Babinski, trying to get a Babinski, and their whole leg pulls away. That's a pretty strong flexor withdrawal response. It's normal for us to kind of pull away when you have a noxious stimulus, but something that would normally not be that noxious, you shouldn't see this dramatic, their leg just goes into full spasm and this full flexor withdrawal response. We can have abnormal timing of muscle activation, so initiation of movement. They're often, upper motor neuron disorders are often slow if you tell them to move and it takes them a second to start actually activating the muscle. They have to really think about it because they have limited pathways already damaged to use to try to get that muscle to start moving. And how fast they can develop the contraction, the speed or power with which they can create their muscles, the rate of force development can be slower, okay? And then the muscle contraction, when they go to turn off the muscle, there's a delay, and they can't turn the muscle off as quickly. So they turn it on, and then you tell them to relax, and they got to think about it and really concentrate to let the muscle relax. There can also be co-activation of agonist and antagonist. So they try to move their limb, you're trying to bend their elbow, but their triceps also turning on and fighting them. So there's overlap of the agonist and antagonist oftentimes in upper motor neuron syndromes where they have difficulty just turning on one muscle and letting the other muscle relax and vice versa, okay? Especially like extending the elbow. They have a hard time turning the elbow on, plus they've got a spastic, elbow flexor because their rubrospinal tract's a little overactive, and they have a hard time fighting this overactive, this muscle won't turn off while they're trying to extend their elbow. So it makes it hard for them. Same thing with the hip and knee. They have a hard time bending their hip and knee because their quad is overactive and their hamstrings are a little bit hard to activate and overcome the already biased extensor tone of a quad. Common terms used when describing impairments associated with upper motor neuron lesions. Co-contraction, which I just mentioned, is this temporal overlap of agonist and antagonist, which it can be normal under certain circumstances. I mean, when you're especially doing weight-bearing activities or closed chain activities, or if I'm trying to stabilize my, sitting here on my arm and elbows, I've got some contraction of bicep and triceps to stabilize my elbow joints or up the shoulder girdle. But if I'm doing open chain stuff where you're trying to move quickly, you should be able to turn one muscle on and turn the other muscle off. So co-contraction is a common term used associated with upper motor neuron disorders. That this patient is having co-contraction of their, triceps and biceps or quads and hams that you're seeing. There's contracture. Eventually, if you have a muscle that is in a shortened position long enough, you'll actually develop a true contracture where you actually have loss of sarcomeres and actually increase in cross links between muscle fibers, and where you start to get true shortening of the muscle. Not just temporary shortening where the sarcomeres are just kind of overlapping temporarily, then they get sticky and stuck there, and then you actually get reduction in the number of sarcomeres, so the actual muscle starts to shorten and lengthen its actual structure, okay? But that takes weeks and months to occur. But if a patient who always holds their arm like this, if you don't stretch this elbow out every day religiously, a couple times a day, they will eventually get a contracture in their elbow. The muscle will adaptively shorten, but also the joint capsule and ligaments will also start to lose length, and you'll decrease the length of the collagen fibers and get cross-linking, and they'll get sticky and glued together and won't move over each other as well and lead to true contracture. And it's really hard when you're first learning how to assess patients and move their limbs. What is spasticity versus what is contracture? So you start moving a limb and you'll encounter some resistance, and you're going, is that resistance like neuromuscular tone and active resistance I'm feeling from the muscle, or is that just the muscle now it's in a shortened position and the muscle and the joint capsule is also tight? It's all about end feel. You get to that end feel and you go, a true contracture will end up being more of a firm end feel, right? You'll get to that end feel and it won't go any further. Where if you get there and there's still like a little bit of a give to it, and if you do a quick stretch and the muscle fights back at you more, that's more of an end feel that is more of a muscular end feel that is a spastic muscle end feel versus a true, like I'm hitting a hard kind of stop. Not a bony stop, but a firm stop. More of a firm versus more of a bouncy stop. And there's usually a little bit of both going on. And sometimes for some patients, their tone is so high, it's hard to get to the end point of where the actual contracture starts. But some people, it's vice versa. You get it to the contracture before you even elicit a lot of tone or spasticity. Their muscles actually and their joints contracted down through passive fibers length shortening. Contracture is one component of this whole thing, this term called myoplastic hyperstiffness. It's where your muscle gets stiff. And it's a combination of true shortening of the muscle, but also the stickiness of the sarcomeres and how they overlap each other, plus the neuromotor drive to them. There's a combination of things that occur that lead to your muscle being stiff that's not just purely related to shortening of sarcomeres. It's actually, there's a neurologic component to it, control component to it. So this is myoplastic hyperstiffness. Is excessive resistance to muscle stretch due to structural change within the muscle and also due to changes in neuromuscular activity. It's kind of a combination of those things. with the contracture, you get contracture, and you also get this increased weak actin-myosin bonding, even at rest, where they just kind of stay next to each other for so long, they just kind of start sticking together. You also get with myoplastic hyperstiffness select atrophy of type 2 muscle fibers, the fast twitch muscle fibers. So your patients really struggle with fast movement and moving, fast powered movements. It's very common in stroke, common in MS to get myoplastic hyperstiffness. Muscle overactivity is a general term. Muscle contraction that is excessive for the task, caused by excessive neural input to muscles, maybe due to lack of skill in performing the task, anxiety, or pain. So some patients, ask them to do something, and they use too many muscles to do it, and they get overactivity in the muscle more than they need to actually do the task. And this is very common, especially with fine motor control. So the patient, you're trying to get them to do something like button their shirt, and they're using like way too many muscles and not in a fine fractionated way. They're just overactive with their muscles. Sometimes you have to tell them, hey, just let it, or even like Randy on the treadmill, when he's walking on the treadmill, sometimes I can tell when he's really working too hard, and I'm like, just let it happen, relax. Just kind of let momentum carry your limbs forward. You're trying too hard. You're making this harder than it needs to be. He starts getting out of breath because he's got muscle overactivity. He's trying to like fight his own muscles to try to move his limb any way he can, and sometimes that can be counterproductive, where I just have to say, hey, just relax. Let your legs stay back on the treadmill a little longer, and then let momentum fling it forward. Do a good weight shift. If the good weight shift may allow your limb to fly forward without you having to throw it forward or force it forward like that. So. Muscle tone, we've mentioned this for upper motor neuron. Amount of tension in the resting muscle, examined passively. It can be either hypertonic or hypotonic. We have spastic hypertonia, which is more common in upper motor neuron lesions. And then we can have a rigid form that's more common in basal ganglia lesions. So people with Parkinson's disease, they can have a lot of rigidity, but they don't have spasticity. When you tap on their tendons or you move it more quickly, they don't have an increase in response. It's just rigid no matter what speed you move it. You move it fast, you move it slow, it feels the same. Where somebody with a stroke, you move it fast, it tends to get worse on you. Move it slow, they have a different level of tone. Okay? Tap on their tendon, they get clonus, all that kind of stuff. Where Parkinson's, it's just rigid all the time. No matter what speed you move it, it's not velocity dependent. It's rigid both in flexion and extension. So with Parkinson's, they're often rigid when both directions you move the limb. Where with stroke, it's like, especially the leg, when you go to bend the leg up, their extensors tend to be more turned on. So they have spasticity when you try to flex the leg, but not so much when you extend it. Or when you try to extend the arm, they have spasticity because there are flexors in their arm. But when you flex the arm, you don't notice the spasticity. Okay? Where with Parkinson's, no matter which way you move their limb, it's stiff, both directions. Okay? Paresis is a partial loss of strength and movement, occasionally paralysis. Complete SCI is where you get complete paralysis. I mentioned this before. Paresis is partial paralysis, essentially. Spasticity and hyperreflexia. These are all again terms that describe the muscle itself and what's going on the muscle level. The spasticity is this velocity-dependent resistance to passive muscle stretch. Clonus is a term we use to describe where you get this repeated stretch-induced contractions due to spasticity. If you have clonus, you have spasticity. If you have spasticity, you're also likely to have clonus, but you may not. You may have an increase in resistance to when you increase the speed, but you may not actually get clonus. But very, very often, somebody who has spasticity also has some clonus. And really the main places you elicit clonus is at the ankle, when you stretch their gastroc, or at the wrist, if you stretch their wrist flexors really fast, like this. If they've got a lot of flexor tone, and I stretch their wrist, and I hold that stretch, it'll sit there and beat back at me like this. The other places at the elbow flexor is the bicep. I can quick stretch their bicep, and if I hold that stretch, we'll get some clonus. Or Randy will elicit this sometimes as he's walking on the treadmill. If he starts getting really fast and his arm starts shaking, and then next thing you know, his arm gets clonus because he gets a quick stretch to the bicep as he's trying to walk, and then it just keeps quick stretching itself, and he gets clonus, and then we have to kind of like, hey, relax or slow down the treadmill, or just change the way he's moving his arm, and that will sometimes reduce the clonus. I've had times where we've actually had to, is it going to blow up? That's not good if you've never heard that before. That's what you get for buying that stuff off the street, man. Those black market phones, man. Examples of upper motor neuron disorders. So spinal cord injury is an upper motor neuron disorder. Stroke is an upper motor neuron disorder. MS is going to affect upper motor neurons. Cerebral palsy, especially spastic cerebral palsy, is an upper motor neuron type of disorder. And then it's traumatic brain injury, or any kind of a tumor that's involving the brain, cortex, brainstem, or spinal cord could cause an upper motor disorder. Stroke is by far the most common type of upper motor neuron disorder that you see out there. Oh, wow, we're done. We're not done yet, though. We're going to do a case study next. So any questions right now? Yeah.